Okay, sorry lah, I've got someone. Okay. You can start.
Doctor, how many minutes do I have to clock?
Oh, okay. You have 10 minutes to clock. I think 10 minutes to clock, and another 10 minutes to ask to explain your working diagnosis and also your management plan to the father, and then another 5 minutes for Viva lah later at the end. Okay.
Alright.
So total 25 minutes. Okay, you can start now.
Okay, Assalamualaikum. Nama saya Ali, Doktor Perubatan kat Sosmed. Okay, boleh saya tahu nama Encik?
Nama saya Ali juga.
Ali. Okay. Ini anak Encik?
Ya, anak saya, ya.
Nama dia Ali juga?
Ya, Ali juga.
Okay, dia umur berapa?
Umur dia setahun. Setahun. Cukup setahun semalam.
Cukup setahun. Okay, jadi semalam masuk hospital?
Ya.
Masuk emergency?
Macam saya pergi kecemasan. Pukul 12 malam saya datang.
Kecemasan? Okay, bila malam pukul berapa?
Pukul 12.
12. Okay, masuk hospital kenapa?
Anak saya sawan semalam.
Oh, sawan. Pukul berapa Encik perasan dia ada sawan?
Mula dia tidur. Pukul 10 dia tidur.
Okay.
Lepas tu kita pun tengok TV, habis tengok TV tu nak tidur. Lepas tu dengar bunyi, macam bunyi orang jerit macam tu, macam bunyi pelik lah, bunyi jerit. Jadi kita pun pergi bilik dia tengok. Tiba-tiba nampak dia dah ketar-ketar dah. Tangan kaki semua ketar-ketar.
Oh, okay.
Macam gigil-gigil macam tu.
Gigil. Ni pukul berapa?
Saya tengok jam dalam pukul 12 lah waktu tu.
Pukul 12. Okay. Dia macam tu berapa minit?
Saya sampai hospital dalam pukul 12.10. Waktu tu dia tak berhenti lagi.
Tak berhenti.
Doktor tu kata dia sawan lagi.
Masih sawan lagi, jadi lebih 10 minit masih ada lah. Okay.
Ya, lebih.
Ada perasan lagi tak macam dia sawan, dia ada macam conscious ke? Conscious.
Waktu sawan tu memang dia tak sedar. Dia memang tak sedar. Saya panggil dia, kita panggil dia, adik, dia tak sedar.
Oh, okay. Dia tak sedar. Jadi bila dia mula sedar?
Dekat kecemasan tu, doktor tu masuk ubat kat punggung dia. Lepas tu terus berhenti. Sawan berhenti tapi dia tak sedar juga. Dia macam penat lah. Nampak dia nangis tapi dia penat. Dalam lepas setengah jam lepas tu baru dia sedar. Baru dia minta susu.
Dia ada sawan lagi selepas tu?
Tak ada. Sampai sekarang tak ada lagi.
Oh, jadi satu kali saja. Sebelum ni dia pernah ada sawan tak?
Tak pernah. Dia tak pernah sawan.
Ni pertama kali ya? Okay. Ada perasan dia ada demam tak?
Itulah, dia tak demam. Dia memang sihat saja. Tapi bila sawan tu memang kami rasa panas lah badan dia. Bila bawa pergi hospital tu, doktor kata 40 suhu dia.
Oh, okay. Okay. Bila dia sawan, dia tangan kaki dia memang macam gerak
Memang tangan kaki ketar-ketar macam gerak-gerak macam tu.
Okey. Mata dia
Mata dia
macam
pandang
mana?
tepi. Dia pandang tepi. Dua-dua mata dia pandang kanan macam tepi.
Okey. Dia ada muntah?
Tak ada.
Tak ada.
Hmm.
Dia ada masa sawan dia ada macam kencing ke, buang air besar?
Ada, dia terberak.
Dia terberak. Okey. Okey, bila dia sedar, dia ada macam dia menangis saja.
Dia nangis, lepas tu dia tidur. Lepas setengah jam macam tu dia bangun.
Okey. Selepas dia bangun, dia dah okey ke?
Dia okey lah. Sekarang dia okey je, dia balik macam biasa.
Okey. Okey. Dia ada simptom lain macam jadi sebelum ni memang tak ada masalah, dia tak ada demam ke, muntah macam seminggu lalu ke?
Dia adalah sesama sikit, tapi sikit saja.
Sikit.
Batuk sikit-sikit sesama dah daripada semalam lah, semalam.
Oh. Semalam.
1 hari lah, baru 1 hari.
Dia ada merah kat kulit, rash,
Tak ada.
merah-merah, tak ada.
Tak ada.
Baru ni dia ada dia macam ada kurang makan, kurang minum.
Tak ada pun, okey je.
Tak ada pun lah.
Tak ada.
Okey. Okey. Dia selalu ada follow up untuk tumbuhan, macam untuk
tak ada.
monitor
Dia
tumbuhan.
okey je. Kita pergi
Dia
klinik
okey.
kesihatan, tapi okey je. Doktor kata dia tinggi,
Okey.
besar, semua okey.
Semua okey ya? Okey. Dalam keluarga, dia ada adik-beradik ke? Abang, kakak?
Dia anak keempat.
Anak keempat. Abang kakak dia ada macam sawan dengan demam, pernah ada tak?
Tak ada.
Tak ada. Okay. Okay, dia lahir kat hospital ke?
Lahir dekat hospital.
Dia lahir dia lahir kat hospital. Hospital mana?
Dia lahir kat sini lah.
Sini. Dia lahir macam mana? Dia macam
Dia lahir okey, normal
ke
saja.
atau
Normal, tak ada masuk ward.
normal? Okay.
Dia sihat je, dia kuning pun tak ada.
Okay. Berat badan berapa bila dia lahir?
3.7 kilo.
3.7. Okay. Dia ada minum susu badan sejak lahir.
Dia minum susu badan sampai 6 bulan. Lepas tu dia makan lah, kita bagi dia makan.
Sehingga 6 bulan 6. Okey. Siapa jaga anak kat rumah?
Dia kita hantar pengasuh. Saya dengan isteri kerja kan. Hantar pengasuh lah.
Okey. Jadi baru ni dia memang tak ada ciri birit selalu ke, tak ada?
Tak ada.
Dia pernah masuk hospital tak?
Dia tak pernah.
Pernah. Jadi sekarang dia ada ambil ubat?
Tak ada.
Tak ada. Baru ni dia pernah macam pergi travel ke?
Tak ada.
Tak ada. Tak ada travel. Ada kucing kat rumah? Ada tak?
Tak ada.
Tak ada.
Tak ada. Ali?
Dia ada macam dalam keluarga dia ada yang ada sakit kronik.
Contoh macam mana? Sakit kronik tu apa? Tak ada yang kanser ke, tak ada dalam keluarga saya.
Macam kanser atau ada masalah darah ke, tak ada?
Tak ada. Adalah macam darah tinggi, kencing manis tu adalah. Mak ayah saya, mertua.
Oh, okay. Encik ada merokok ke?
Saya tak isap vape je. Tak isap rokok.
Wait ya. Rumah jauh tak dari hospital?
Dekat je. Tu yang saya 10 minit saya sampai dah. Dan lepas tu 10 minit doktor dah bagi ubat.
Okay. Okay. Dia ada vaksin. Aduh. Okay.
Vaksin? Semua cukup.
Alright. So I have to explain to the parents.
Okay, sabar. Kita summarize dulu. I think you summarize first. And then you explain to the parents. Okay, summarize first.
Okay, my patient, Ali, 1-year-old boy, was presented to emergency department of suspect with a complaint of seizure and fever for 1 day duration, with 1 episode of seizure and fever for 1 day, and then I think that's all.
Okay.
I think that's all.
Okay. So would you like to explain to the father your working diagnosis?
So currently my working diagnosis is
you have to explain to the father. Okay. So doktor, anak saya ni sakit apa sebenarnya doktor? Saya risaulah.
Okay, sekarang kita suspect dia ada febrile fit sebab dia ada demam, dia ada sawan tapi dengan sawan dengan demam. Jadi condition ni benign, macam tak
benign lah, maksudnya bukanlah benda yang bahaya.
Bukan bahaya. Okay.
Tapi apa yang buat dia sawan? Orang lain demam tak sawan pun.
Selalu sawan ni sebab jangkitan macam dia ada macam kalau dia ada demam ke atau pernah ada batuk sebab dia ada selalu sesama. Jadi ada kemungkinan tinggi. Dia juga sawan dengan demam ni selalu jadi pada budak dari 3 bulan sehingga 6 tahun.
Okay.
And okay. That's all. What else?
Kira dia ni bukanlah macam sawan apa orang kata sawan babi tu kan. Ni bukanlah macam dia besar nanti dia sawan ke yang ni sekali je.
Okay, sekarang sebab dia tak ada sawan lagi, jadi ada kemungkinan tinggi dia akan ada lagi sebab sawan yang demam ni selalu tak ada macam yang kat otak macam tak serius lah.
Maksudnya dia tak beri kesan kat
Dan
otak
juga dia
lah.
ada tubuhan dia macam biasa. Sorry?
Tapi bila besar nanti dia boleh dapat sawan ke sampai besar? Ke tak ada?
Dengan kemungkinan tak tinggi sangat.
Okay. Jadi apa yang doktor nak buat sekarang? Sekarang ni apa yang doktor nak buat kat anak saya? Memang doktor confirm ke yang ni memang tak bahaya?
Sekarang
saya risaulah.
Sekarang kita nak buat blood test dengan blood culture untuk tengok kalau dia memang ada jangkitan ke tak. Kalau memang ada jangkitan, kita nak buat swab kat swab throat, swab tekak.
Untuk apa Kenapa check tekak
Kalau dia macam ada infection jangkitan. Okay, kita nak juga check kencing dia, buat ujian kencing untuk juga check untuk ada jangkitan ke tak.
Okay, lepas tu macam ni doktor, yang saya risau ni macam ni. Saya punya anak buah ada seorang. Dia sawan juga. Lepas tu pergi hospital, doktor ambil tulang belakang dia. Saya risau. Saya takut lah ambil tulang belakang ni doktor. Kena ambil tulang belakang ke? Kena ke ambil tulang belakang tu?
Belakang?
Ni ambil tulang belakang tu. Saya punya anak buah tu sampai jadi lumpuh sebab ambil tulang belakang.
Sorry, I did not get
ambil
that.
ke doktor? Ni anak buah saya kan, dia masuk dekat dia
culture.
sawan juga. Lepas tu doktor sana ambil tulang belakang dia sampai jadi lumpuh. Anak saya kena ambil tulang belakang ke doktor? Saya takut lah.
Okay. Untuk dia tak perlu buat tu sebab dia memang tak ada sebab dia memang dia tak perlu untuk kita nak check kalau dia memang ada infection. Jadi kita perlu tengok ujian darah dia. Kalau memang ada kemungkinan kita perlu buat tu juga. Tapi okay, I think that's all. Jadi prosedur memang selamat lah, sebab ada risiko tak tinggi.
So kena ambil lah itu dalam belakang.
Untuk sekarang tidak.
Okay. Sekarang tak perlulah ambil dalam belakang Okay lah. Tak perlu macam tu, doktor. Okay lah. Okay, terima kasih doktor ya. Okay, good. Okay, good. Okay, so so we've got 5 minutes untuk Q&A kan. Okay, I want to ask you questions. So what is your working diagnosis?
So currently my working diagnosis is fit, and it's because as this patient currently has a seizure and fever for around 10 minutes, and then after upon taking medication through rectal, there was no other further seizure, which for until now, which might most likely to be a benign condition. Okay, and then and it's also evidence that he had a recent recent infection, most likely infection, as he had as he had a recent infection, URTI. Okay, so
okay, what is your differential diagnosis?
Okay, my differential diagnosis is meningitis. Meningitis, as he has also fever and also seizure, which can also be also one of the differential diagnosis. However, and the child also cried and also slept, which might also be indication. Okay. However, I would like to check further for any Kernick sign or Bosinski to confirm that.
Okay.
My other differential diagnosis will be any metabolic, like hypoglycemia, hypocalcemia.
Okay. Good.
So
okay. So what investigation do you want to send?
So for investigation, I would like to do a full blood count.
Okay.
To identify if there is any infection, blood culture, and sensitivity, and then I'll also do a random blood glucose.
Okay.
All right. So then I will also do check for serum electrolyte, like if any for sodium, calcium, and then and or I also have to do puncture.
Okay. Okay. Would you do lumbar puncture to all everyone, every patient that came with this similar presentation?
For lumbar puncture, it is indicated if the child is less than 1 year old, and
Mm.
it's a if the febrile seizure is complex,
Is it?
where it lasts more than 5 minutes, and then if there's multiple seizures within that 24 hours, that is indicated as lumbar puncture.
Mm, okay, 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 okay. It's okay. 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 Next
They are
question.
more likely a high indication
Uh,
to have lumbar puncture.
okay. Okay. So in this case, okay. Uh, okay. You mentioned about electrolyte, kan? What type of electrolyte that usually cause seizure? Which electrolyte imbalance that usually cause seizure?
Um, uh, Sodium, calcium, and magnesium.
Sodium, calcium, magnesium. Okay, good. Okay. Okay. I think good, good. Okay lah. That's all. Okay. So let me give some comments, kan. So I think in general, you are very polite. You introduce yourself. That's very good. And you correctly address the father. You did mention the child's name. That's very good. And so ideally, if you've been given a question, a stamp mentioning the name, so you should use the name. For example, like I've mentioned the child's name is Ali, and then you should say, "Oh, you are Ali, father of Ali." It shows that you actually, and you present yourself as a doctor lah, like in the questions.
Mm,
Okay, you're approachable, friendly. That's very good. Uh, and then you did manage to get the information on the seizure lah. You did try to explore the seizure. Okay, however, there's few things that I think you missed. Okay, first, you've mentioned about your differential is actually electrolyte imbalance, kan? So what usually cause electrolyte imbalance?
yes.
What is usually the cause of electrolyte imbalance?
First will
You
be because of diet.
diet, okay.
Also infection.
How infection cause electrolyte imbalance?
Infection. Um, by or if there's like infection can cause vomiting, diarrhea, so that those will lead to electrolyte imbalance.
Okay, so it's actually ongoing losses, kan? Diarrhea, vomiting. That is actually
Yes.
what cause inilah electrolyte imbalance. Okay, okay. Besides that, what else? What are your differential just now? Meningitis, kan? So how you differentiate
Yes.
meningitis and febrile seizure?
Um, to differentiate is to first first mm, meningitis. Okay, so first of all, it depends on the age. So
Yeah.
for this child, maybe if there's meningitis, they
Mm.
might be more irritable than usual,
Okay,
and
good.
then if they are able to, what is this, express that they are having pain, headache,
Mm.
and then they will have also loss of appetite or reduced feeding.
Okay.
And then they also have nausea and vomiting, and they can also complain of neck stiffness, which will point more towards meningitis.
Okay. Okay. Good. 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 So how do you confirm febrile seizure?
To confirm febrile seizure, uh,
Mm.
so first of all, okay, so we like to do first by investigation,
Mm. Mm.
to do like the full blood count to rule out infection first.
Mm.
Then, if possible, we will do also a lumbar puncture.
Okay. I'm puncture. Okay. Okay. Okay lah. Okay. You should ask also history of fall, head trauma, possible intoxication. Maybe like because the child is 1 year old, maybe he's picking up things on the floor. So maybe he took
Oh,
parents punya medication kan, antipsychotic or anything. That actually cause the seizure lah. Besides that, social history is very important in febrile seizure because it could be actually shaken baby syndrome kan. So you have to ask about the
mm,
social dynamic of the family. Macam you can ask, this is very sensitive question, but you have to ask lah. For example, like how were you as a family? Just a very broad questions. Macam mana keadaan rumah awak? Keadaan keluarga awak macam mana? Rumah tangga awak macam mana? Boleh saya tahu? Boleh. Can I ask some sensitive questions that might be personal to you? Uh, how's the condition in your house? Or how's your household? Atau bagaimana keadaan rumah tangga awak? Macam tu lah. You have to explore lah. Kalau dia tak nak beritahu, then it's okay. But later on, when examination, you have to examine evidence of NAI lah, non-accidental injury. And then you have to ask developmental history. It's very important. Okay, developmental history is very, very, very important. Family history, you have to focus. Okay, for family history, you have to focus lah. You have to specifically ask. You need to ask close questions. Start with open question. Very good. You ask open questions. And anything run in your family, and then focus on like, is there anyone in your family with seizure or learning disability or syndromic, or someone who is looks different than the others, OKU in your family, things like that. Okay lah. Then finally, basically, febrile seizure is diagnosed for exclusion. So as long as you exclude all these differential, then you can confirm febrile seizure. You don't need LP for febrile seizure, regardless it's complex or simple. You don't need LP for febrile seizure. Okay. Okay lah. Any other questions, guys? Okay, Ali, you want to ask any questions? Okay, I've got one tips. Actually, when you clerk a patient, when you clerk a case, don't write while clerking. Okay, especially in like long case kan. It's difficult lah kalau observe long case, for example like in modified long case, maybe it's a bit difficult. Tapi for long case session, please don't write. Okay, ask questions. You clerk first. Okay, clerk first, and then after you finish your clerking, or maybe after like once you confident, once you think you got all the complete information, then you jot down. Okay, jot down in points or doesn't matter lah in what way. Okay, just jot down after you clerk. Okay, lepas tu kalau if you got anything that you miss after you writing your findings and you miss, then go back to the patient and ask. Okay, because in long case, okay, this session is different. It's different lah because I'm actually like emulating the modified long case. Tapi in long case, in traditional long case, you are not being assessed on the clerking. You are assessed on presentation, presenting skills. So doesn't matter lah how you clerk. In fact, kalau you nak clerk, do you have this, all closed questions, it doesn't matter. Directed questions pun doesn't matter, because what we want, we are assessing your presentation rather than your clerking. Okay. So, and in real life pun, clerk patient, and then after that, write, and if anything miss, go back to the patient and ask again. Okay, faham? And clarify, always clarify. And you should always ask the ICE question. Tahu kan? Okay, ask the ICE question, idea, concern, expectation. Ask these 3 questions because you get a lot of information. Because for example, like if you ask me, may I know what is your concern? Apa yang cik risau sebenarnya? So, because I keep on mentioning risau tau. I think I've mentioned like more than 5 times risau. So because you will, you will develop rapport, and you will actually open up more conversation with parents, and you can get a lot of information by exploring the eyes. Okay, because in this case, actually I risau because my nephew had similar problem, had seizure, and then they did LP, and turn out he become paralyzed and paraplegic. So that is my worries lah. Because if you fail to explore, if you fail to tackle or address the worries of your patients, then you are fail lah. Okay, because managing patient is not only come up with diagnosis. You are not managing illness, you are managing patient. And in this case, you are managing the parents, not only the patient. Because parents are your patient. Okay, so ask about the idea, concept, expectation. Okay, I think that's all the questions. Is there any questions?
Doctor.
Okay,
I
let's
want to
discuss.
ask.
Okay.
I want to ask whether it's matter the eye roll upward ke rolling to the
Yes,
right ke left
it's
ke?
matter. It's matter. For us, it's not matter. Okay, for yourself, it's not matter. But for neurologists, it's matter because it determines where is the lesion. Kalau this is epilepsy, for febrile seizure, it is not that important lah. Tapi kalau if this is epilepsy, it's important because it point us where is the lesion. Okay? Kalau you left lateralization kan, then usually the lesion is at the left side of the brain. Kalau right lateralization, then it's right side lah.
So for this patient, dia generalized tonic-clonic kan?
Yes.
Maksudnya kalau mata dia roll to the right tu indicate lesion dekat right ke?
No, because febrile seizure dia tak ada lesion. In febrile seizure, there's no brain lesion. It's because of the sudden increase in temperature cause the membrane instable. Tapi possible because the brain development, myelination of the brain, it doesn't occur globally simultaneously. So sometimes some area maybe tak fully myelinated or tak fully developed. So dia prone untuk seizure lah. So maybe seizure dia started from there, tak tahu. Tapi tu lah, lateralization is important lah. It has to be included. When you describe seizure kan, you have to include the morphology in detail. Okay, in detail, the duration, the type of seizure, is it tonic-clonic, or is it clonic, or is it tonic? Okay, and then during saliva, incontinence, bowel or bladder incontinence, the ictal post-ictal drowsiness, any presence of thought paralysis kan. Okay, lepas sedar nampak dia okey ke atau nampak badan macam lemah? So sometimes parents kata, oh, lepas dia okey tu doktor, dia macam tak nak pegang lah. Dia macam tak nak pegang botol susu. No, bukan dia tak nak pegang, actually dia ada thought paralysis over the right side. So dia tak pegang. Ataupun anak dia contoh lah, 3-year-old dah ada hand preference kan. And then after seizure, dia tak guna tangan kanan, guna tangan kiri je. Then you know it's a thought paralysis lah. Maybe it's a complex seizure atau something else. Okay. Yang ni tadi siapa nak tanya?
Saya doktor. Nizam nak tanya. Okey.
Okay. Apa tanya? Tanya dia.
Cuba.
Apa dia?
Doktor, ni ada orang tanya dalam chat. what is the
itulah
importance of
saya nampak dah.
classify? Okay.
Okay. So basically, the importance is the prognosis lah. You know, because those with complex seizure, usually complex seizure is associated with something else lah. Okay. Complex seizure possible there's something different etiology that you may have to work out further. Sometimes complex seizure you tak discharge awal lah. Kalau febrile seizure you can actually discharge. Tapi kalau complex seizure you cannot discharge. You have to admit and KIV further workout because it can be something else. And besides the prognosis lah, kalau patient datang for complex seizure, chances are higher risk of recurrence rather than compared to the simple seizure. It's more to prognosis lah rather than anything else. Okay, tadi siapa nak tanya tadi?
Doktor, I think you have answered the question.
Oh, okay.
Okay, thank you, Doktor.
Okay. Anything else? Remember, febrile seizure is very common, and you will definitely get this case in your exam. Okay, and febrile seizure is a pathology by itself, right? It's a diagnosis by itself. Okay, it's not. You cannot say because I remember, is it with year 5 or year 3 last time presentation? Your colleague mentioned febrile seizure. The etiology of febrile seizure is meningitis, is electrolyte imbalance, is SOL. No, it's febrile seizure is a diagnosis by itself. Okay, if you got febrile seizure, then you cannot have meningitis. You can get either one. You cannot get febrile seizure secondary to meningitis. No, that's not right. Febrile seizure is febrile seizure. It's similar to chronic pain. You tak boleh kata chronic pain secondary to migraine. No, that's not right. Because chronic pain is a diagnosis by itself. So you akan kata diagnosis is chronic migraine. The second is chronic pain. Okay, faham? Okay.
Doctor,
Okay, next.
should be the complete diagnosis is febrile seizure secondary to RTI or UTI.
Yes. Tapi kalau you tak jumpa apa source pun, you just say febrile seizure secondary to viral. And you don't need blood culture in febrile seizure. You don't do blood culture in febrile seizure unless if you think it's infectious. You think you need to start antibiotic. Total white dia high ke, then you may need to do blood culture lah before start antibiotic. Tapi if not, you don't. Blood culture is not routinely done lah in febrile seizure. But you need to check the electrolyte. Electrolyte memang you kena check, especially the calcium, sodium, and magnesium. Okay, great. Okay, so next question. Next session. Next patient.
Doktor nak tanya, sorry.
Okay.
This patient, is it febrile fit with status epilepticus?
Okay, because this case, dia up to 15 minutes kan. Usually more than 15 minutes, we will call it as status lah, because you know any seizure that lasts more than 15 minutes will not be aborted unless you intervene. So you can actually say you need to clarify from the parents how long is the duration, and if you confirm this is more than 15 minutes, you can say lah this is febrile seizure with status epilepticus. Okay.
Okay, Doktor.
Okay. Okay. Sorry, Doktor apa? Tak tahu, 5 minit je sekarang. I thought it's 15 minutes.
Oh, kita orang baca 5 minit.
Dekat mana?
Kat mana?
Dalam page protokol lah.
Sekejap saya check.
Maybe lah 5 minutes. I can't remember. I rasa 5 minutes. Maybe 5 minutes. Check lah. 15. Up to date cakap apa? Up to date.
CPG. Kalau up to date, kalau febrile status epilepticus more than 30 minutes.
Kan. So maksud dia apa dia macam ni tadi? Febrile seizure is more than 50 minutes. Apa dia?
Untuk cut off febrile seizure tu 15 minit. Kalau simple less than 15. Kalau complex more than 15. Lepas tu tambahan daripada up to date, kalau febrile status epilepticus more than 30 minit baru kita kata status apparatus with progressive.
Dia macam ni, dia status, definition of status is 30 minutes. Okay. 30 minutes is definition of status, okay, regardless of what is the cause of seizure. However, if usually lah, based on study, any seizure that lasts more than 15 minutes will not abort until you intervene. Faham tak? For example, if you got a child 20 minutes dah seizure, kalau you tak buat apa-apa kan, dia akan jadi status. Okay, he will remain seizure until status. You cannot wait until 30 minutes baru you nak intervene. Faham? So after 15 minutes, kalau tak aborted, then definitely you have to intervene because you know this child will most likely be status lah. You faham? So I think it's 15 minutes. The cut off point. Okay. Tapi better check lah nanti, takut I lupa. Ni. 5 minutes or more. Okay. Considering the need for rapid evaluation in more than 5 minutes or continuous seizure. Okay. More than 5 minutes. Okay. So usually more than 5 minutes. Because more seizure, febrile seizure is not more than 5 minutes. It's very short duration. Okay, good. So 5 minutes lah. So kita fix to 5 minutes. Okay. Okay, next. Ataupun ada soalan?
So memang kita tak buat lambat panca.
No, we don't do lambat panca. Once you decide to do lambat panca, then the diagnosis is different lah. Dia tak boleh kata febrile seizure. Okay. Okay.
Okay, doktor.
Who's next?
My side. Me, doktor.
Okay. So so the case is you are a houseman in ward general pediatric ward, suspect. Okay, you were asked by your MO to clerk a case to clerk Mr. Abu, okay, who is father of Ahmad, who actually admitted because of tadi lupa je. Admitted because of shortness of breath and lethargic. Okay, Ahmad is a 7-year-old boy. 10-year-old boy. Who is admitted because of shortness of breath and lethargic. Okay. Please, so I give you 3 minutes to think, and then we discuss. This is a tough question, so be careful. So similar lah, I give you 10 minutes to clock, and then you need to do summary, and then another 10 minutes to explain to the father, and then 5 minutes for Q&A. Okay, start from now.
Like correct? Can you hear me?
Okay, ready dah?
Belum lagi.
Tak kisah. Kalau you ready, boleh je.
Okay.
Sekejap, I ambil air sekejap. Sekejap, bagi I 1 minute lah. Sekejap Okay, boleh start.
Before that, Doctor, my apa? Kalau dengan suara yang kata apa? Because my house currently renovate, so ada bunyi bertukar-tukar sikit.
Tak apa, okay
I
je.
don't know
Okay,
why. Okay. Nanti kalau ada distraction, sorry ya.
Okay, tak apa.
Okay. Encik Abu. Encik Abu, right? Okay.
Yes.
Okay. Encik Abu datang bawa anak nama Ahmad ya?
Ya, saya. Ya.
Okay. Datang sebab apa Encik Abu?
Anak saya nampak lemah lah. Dah 3-4 hari.
Berapa hari?
Dah 3-4 hari.
3-4 hari? Okay. So dia datang. Oh. Kenapa tu Encik Abu?
Itulah dia nampak. Dia tak lagi sekolah. Dia kata dia tak larat dah. Actually dah seminggu dah tak pergi sekolah. Tapi 3-4 hari lah yang dia kata dia tak larat nak jalan. Dia kata jalan sikit nampak mengah.
Oh. So datang ni disebabkan penat-penat, and then Cik Abu datang ni sebab dia lemah ke ataupun dia dia semakin lemah dan juga datang dengan sesak nafas, sesak nafas. Oh.
Bila dia jalan tu nampak bila dia jalan nampak penat sangat. Nampaklah dia mengah.
Oh, faham. So dalam seminggu ni lah, seminggu lepas dia berlaku lemah-lemah.
Minggu ni nampak dia lemah.
Okay. So nak tanya, saya minta maaf saya nama Dr. Azlan. Saya nak bertanya-tanya lah sikit dengan Cik Abu pasal anak ni. Okay. So nak tanya pasal lemah tu, dia lemah disebabkan dia tak makan ke ataupun macam mana? Nak tanya pasal lemah.
Dia tak aktif lah, dia nampak tak aktif. Anak saya ni dia aktif, petang main bola, memang masuk hutan, mandi lombong semua. Tapi memang dia nampak lain lah. Nampak pucat, lepas tu nampak tak bermaya sikit. Macam kalau makan pun tak nak nampak tak berapa selera. Tapi yang paling saya perasan kalau jalan, dia tak naik tingkat 2 dah sekarang ni. Bilik pun dia tidur kat bawah je, atas sofa je. Dia kata kalau naik tingkat 2 dia penat, dia kata.
Oh, okey, faham. Okey. So nampak pucat lah muka dia.
Nampak pucat lah, tak larat kan. Saya tak adalah pucat macam mayat tu, tapi nampak pucat lah.
Okey, saya nak tanya, ni berlaku sejak seminggu lepas lah.
Seminggu lepas.
Okay. Keluarga lain ada yang kena ke macam ni?
Tak ada, semua sihat je. Dia seorang je.
Oh, dia seorang je lah. Okey, nak tanya. dia sesak nafas kan. Dia sesak nafas bila dia buat exercise, even nak naik tangga pun masalah kan. Okay.
Ya, betul.
Ada orang kata apa simptom batuk tak? Batuk ataupun
Batuk
demam
dia ada
ke?
juga. Dia ada demam macam ni. Dia asal dia start dengan demam. 2 minggu juga dia demam tu. Tapi kita orang tak adalah buat apa-apa sebab ada demam biasalah kan, budak-budak sekolah ni demam. 2 minggu juga demam. Lepas tu, lepas demam tu lah.
Lepas demam tu berlakulah yang lemah-lemah badan ni, lepas tu hilang selera makan, lepas tu dia sesak nafas lah.
Betul.
Tanya, demam tu dia kata ada menggigil tak?
Waktu awal-awal tu memang gigil lah, memang panas badan dia.
Okey. Ada ruang-ruang badan ke kat badan?
Ada, memang dia ada. Waktu tu dia ada macam ruam, macam ada merah badan dia.
Oh, nampak merah lah. Okey. Okey, nak tanya pasal batuk tu. Nak tanya pasal ruam tu. Ruam tu satu badan nampak merah. Memang nampak merah satu badan.
Bukan satu badan, dia macam banyak kat badan lah, kat belakang, dekat kaki, banyak kaki ada juga. Banyak kat badan lah sebenarnya.
Ruam tu tak sakit lah dia kata. Ada tak dia cakap?
Tak sakit. Tak sakit.
Tak sakit. Okey. Tu demam. Pernah check tak? Berapa dia punya temperature?
Ada sampai 40. Saya rasa lama teruk lah waktu tu. Kita ambil lah klinik, dia bagilah antibiotik. Tapi lepas tu bukan sama je. Tapi dia lepas 2 minggu hilang lah.
Dia makan antibiotik?
Makan antibiotik.
Lepas tu hilang? Dia tak hilang?
Lepas tu hilang.
Okey. So lepas tu dia datang pula dengan lemah-lemah badan.
Lepas demam tu, lepas dalam seminggu lepas demam tu baru dia start lah. Tak macam lemah.
Okey, faham. Okey, nak tanya pasal batuk tu dia ada kahak tak ke masih ada lagi sekarang? Dia dah hilang?
Tak ada kahak pun. Batuk tu tak adalah batuk kahak pun. Dia sakit tekak sebenarnya. Dia lebih pada sakit tekak lah. Sakit tekak lah sekata. Batuk tu sikit-sikit je.
Okey. Alright. Okey, nak tanya dalam keluarga ada asma tak?
Tak ada.
Ataupun anak encik ni dia ada lelah asma ke?
Tak ada.
Tak ada. Okey. Nak tanya lagi, dalam masa dia kecil, dia ada masalah jantung tak?
Tak ada. Dia tak ada masalah jantung. Kenapa ada masalah
Masalah
jantung
ke? Berlubang ke?
Anak saya ada masalah jantung ke, doktor rasa?
Oh, saya tanya sebab dia sesak nafas kan. Mungkin sesak nafas ni boleh disebabkan jantung berlubang.
Oh, okey.
Saya tanya je. Okey.
Nah, mak mertua saya ada masalah jantung. Tapi ada sebab-sebab dia ni tak adalah bengkak-bengkak pun.
Okey. Alright. Selain demam dan batuk tu, okey, dia ada muntah-muntah tak? Muntah-muntah sakit?
Tak ada.
Berit-berit?
Tak ada muntah-muntah. Berit pun tak ada.
Kalau nak tanya pasal pemakanan ni boleh?
Boleh.
Okey, dia makan sebelum ni kurang makan ke ataupun masa ni je dia hilang selera makan?
Yang ni lah, waktu ni lah, dalam seminggu ni lah, dia nampak dia kurang sikit. Waktu demam itu memanglah kurang sikit. Tapi yang seminggu ni yang dia nampak lemah. Saya rasa sebab dia penat sebenarnya. Bila dia makan tu, macam dia penat. Kita orang bagi bubur je kat dia.
Okey. Okey, nak tanya dalam keluarga tak ada apa-apa, tak ada isu sama dengan anak ni kan? Okay. Nak tanya pasal dia punya sosial. Kat sekolah dia aktif tak?
Dia aktif.
Pembelajaran dia macam mana?
Anak sini murid cemerlang sekolah.
Oh, bagus.
Kelas pertama memang dia sangat bagus. Saya memang bangga lah dengan dia. Contoh. Karena saya fikir macam mungkin juga masalah jantung sebab mak mertua saya pun cakap tak boleh makan lah, pucat. Tapi mak mertua saya tu dia sembab. Dia ni tak ada sembab.
Oh. Kenapa cik kata ada masalah jantung? Dulu masa lahir tu dia ada doktor kata dia ada masalah jantung.
Tak ada.
Oh, tak ada.
Anak saya okey je. Lahir tak pernah masuk ward. Dia tak pernah masuk ward. Dia memang sihat.
Okey, nak tanya pasal sesak nafas, sorry. Sesak nafas tu ada berbunyi tak?
Tak ada. Dia bukan macam lelah tu. Sebab anak saya lagi seorang tu ada lelah. Dia bukan macam lelah. Alamak. Jap. Alamak. Sorry. I've got phone call lah. Sekejap.
Okey, doktor.
Sekejap. Hello, Mr. Ding. Hello? Okey. Hello?
Boleh tanya sikit lagi?
Boleh. Okey. Lagi 3 minit 3 minit je.
3 minit, okey. Ada masalah pendarahan tak dalam keluarga? Masalah darah?
Kejap. Kejap.
Okey.
Okey. Sorry. Orang yang call tu tak letak phone, so bising. Okey, apa dia? Ya, apa?
Ada masalah pendarahan ke ataupun masalah darah dalam keluarga ke?
Oh, tak ada. Keluarga saya tak ada. Macam mana? Darah tu macam mana? Thalassemia ke apa benda tu Saya baca juga. Oh, tak ada. Tak ada. Alhamdulillah.
Okey, nak tanya dalam anak cik ada makan dia tak pernah sakit kan? Dia tak pernah masuk hospital.
Tak pernah.
Ada makan ada makan ubat-ubat ke sebelum ni?
Tak ada.
Cik ada tahu alergi ke?
Tak ada. Anak saya tak ada alergi, tak ada sakit apa-apa.
Okey. Rasanya itu sahaja.
Okay, good. Okay, so can you summarize?
Okay. 10 years. Sorry. Okay. 10 years old Malay boy presented to emergency department. Okay. With complaint of lethargy for 1 week, and then with worsening shortness of breath for 1 day.
Okay.
It was the child has history of fever for 2 weeks associated with coughing and rash, and the fever resolved, the feverish condition resolved after taking antibiotics. For the condition, the boy absent from the school about 1 week because of the worsening lethargy and less active and low beta tolerance. it was the lethargy was associated were 1 week prior. The lethargy occurs 1 week before, associated with pallor and loss of appetite. Okay, had reduced effort tolerance. Okay. Otherwise, there is no history of vomiting and diarrhea, no history of family bleeding disorder. Okay. No family, no asthma.
Okay.
And sugar. I think that's all.
Okay. Okay, I just want to comment on your summary lah. Okay, try to confine your summary to 2 or 3 sentence. Yang tu kan summary lah. Actually yang you present tu is a presentation of the case. It's okay. So, okay, now explain to the father. Okay. So doktor, anak saya sakit apa doktor? Bukan sakit jantung kan? Dengar tak?
Tak dengar.
Oh, tak dengar sekejap Oh, sorry. Okay.
Dengar.
Anak saya ni sakit apa? Bukan sakit jantung kan, doktor kan?
Okay. Okay. Firstly, saya mungkin kena buat investigation, buat untuk tahulah dia ada masalah jantung ke tidak. Kita kena masuk ward dululah. Okay. Nanti untuk jantung tu, sebab dalam family pun ada masalah jantung juga kan. So mungkin doktor nak check dululah, then baru boleh inform betul lah. Dan kami disebabkan anak kecil ni dia lemah-lemah badan kan, dia dia perlu masuk dalam ward untuk bagi dia nutrition support, feeding support, okay? Untuk kembalilah.
Okay. Jadi apa penyakit dia doktor?
Penyakit dia mungkin yang boleh saya ni differential ke doktor?
Explain lah. Differential tapi explain to the father. Just want to see how you explain.
Okay. So disebabkan ada jangkitan masa 2 minggu lepas kan. Mungkin jangkitan tu mungkin belum sembuh lagi. So nak check juga nanti dalam ward. Okay. Jangkitan kat paru-paru ke. Okay. Nak tengok sebab dia ada juga ruam-ruam badan. So mungkin jangkitan daripada jangkitan yang lepas lah. So nak check juga. Lepas tu yang kedua saya nak check pasal ada masalah jantung ke tidak. Okay. Yang ketiga nak check anak encik ni ada mungkin ada anemia anemia yang tak tahu, anemia ni kurang darah, tak tahu kalau memerlukan blood transfusion mungkin
anemia ni kurang darah macam leukemia tu doktor.
Okay. Leukemia ni boleh juga disebabkan leukemia. Leukemia ni kalau encik tahu dia adalah kanser sel darah putih. Tapi nanti mungkin juga akan di investigate juga untuk okay. Okay lah. So kira anak saya akan masuk ward berapa lama ni doktor? Lama tak? Kalau kita tahu apa sebab dia lemah badan tu kan, mungkin boleh balik awal lah. Kalau tak tahu lagi mungkin kena tahan ward dalam minggu 2 lagi.
Okay.
Tapi kena tahu juga lah apa sebab dia
ambil darah je kan?
lemah badan.
Okay. Doktor akan ambil darah je lah kan. Tak ada ambil apa buat belah-belah ke, tak ada kan. Tak ada operate ke apa.
Itu belum tahu lagi, tapi nanti saya akan inform nanti balik lah. Kalau ada perlukan, tapi macam first dulu kita ambil darah dulu lah.
Oh, okey lah macam tu doktor. Okey, terima kasih doktor .
Okey, aman.
Okay, good. So I think your approach is good. I can see you are thinking. Okay, you've got a few differential in your brain while you're asking question. That shows you are thinking lah. And again, this is quite a difficult case. But as fifth year, I expect you to able to tackle lah. However, I think you are lacking of focus. Not in the sense that too bad. It's not too bad anyway. So it's just a bit of lacking of focus because a good doctor will explore into depth every complaint. Okay. So macam contoh macam the father complain about lethargic kan. So you have to think, okay, what caused lethargic? Is it anemia? Or is it malnutrition? Or is it because hyperdynamic status, hyperdynamic condition, or high cardiac output, or is it actually heart failure? Yeah, and then you have to associate lah dengan other things, and then you explore about lethargic. What do you mean lethargic? Is it all the time, or is it when at rest, or lethargic upon walking? How many distance? You have to clarify. Sama macam NYHA, you are classified, you macam measuring. You have to quantify everything because it will help in your management lah. Okay. Is it lethargic all the time at rest, ataupun after walking like 10 meter or 100 meter, or after climbing stairs, after strenuous exercise? Okay, you have to clarify that. Okay, and then about the shortness of breath, again, very good. You ask about any noisy breathing. Then you should ask, is it all the time ke, or only when exertion? Lepas tu you ask, good lah, you ask about asthma semua tu. And then you because this sound like chronic tau, even though dia kata mak ayah dia kata baru 1 week kan, tapi it's actually the illness occurred like 2 weeks ago, dah ada demam kan, fever for 2 weeks. And you have to think, is it associated, the lethargy, is it associated, or is actually the same things that is not fully covered? So you have to decide on that by asking few questions lah, detailed question. Macam you should ask about other constitutional symptoms. This could be TB ke kan? This could be TB, you know. Ataupun you boleh, this could be something yang more sinister like cancer. So you can tanya lah, loss of weight, loss of appetite, and then you can tanya pasal night sweat, chronic cough. You tanya lah chronic cough, you tak tanya chronic cough, tapi you tanya pasal cough kan. So and then ada contact, ill contact. Okay, good, you tanya ill contact. So things like that lah. Okay, and you need to think. Okay, usually in medicine kan, you should try to compile and or reconciliate, ataupun apa, what the word, you should try to correlate all the presentation, all the symptoms and signs to explain, to be able to be explained by one pathology. Okay, it's very rare for a person to have like 2 or 3 pathology in the same time. Usually it's the same pathology that give rise to complication or give rise to different presentation. So in this case, you can try to correlate. Oh, patient ada shortness of breath, and dia ada lethargic, especially ayah dia kata bila naik tangga tak boleh, pergi sekolah tak boleh. You can tanya, pergi sekolah kenapa tak boleh? Dia pergi sekolah naik apa? Because I will tell you that the child cycle to school. Dia cycle to school, kelas tingkat 3. So this will give you alarm lah. Oh, is it because dia kena climb stairs? Or is it because dia kena exertion? So kalau dia pergi sekolah naik kereta, maybe tak affected so much kan. So you have to clarify all of this lah. And then because you need to combine all the symptoms, so shortness of breath plus lethargic, and then fever 2 weeks. So there must be something kan. Most likely is infection lah. kan? It's something to do with infectious. Okay, nanti I sambung. Jap. I ada someone. Sekejap. Sorry lah, a bit busy lah this morning. Give me like 10 minutes boleh tak? Nanti I sambung balik.
Boleh doktor.
Okay, sorry lah, kesian you guys. Banyak sangat problem. Dengar kan?
Okay. Dengar.
Okay. Okay, so apa lagi? What else? Okay, so what is your working diagnosis?
Okay. My working diagnosis. First is unresolved infection.
Unresolved infection. What infection?
Oh, okay. Maybe first of
what is the source of infection?
pneumonia. Pneumonia.
So you think it's unresolved pneumonia, chronic pneumonia?
Sorry, doctor. Okay. From
what support your diagnosis?
Okay. Diagnosis. I list diagnosis. First, could be heart failure. Secondly, it could be rheumatic heart disease, acute leukemia, and then infection.
Okay, good. Okay, good. So what support your diagnosis and what against your differential diagnosis? So what support your different diagnosis of pneumonia? What support your diagnosis of pneumonia?
Because of the history of infection, fever, cough, may present with shortness of breath if unresolved.
Okay.
And then he took there is history of taking antibiotics.
Okay.
Lagi? Pneumonia.
Okay, lagi? Ada differential? What against pneumonia? So what against pneumonia?
Against pneumonia could be tadi tak tanya pasal prolonged cough. So okay, and then
is it common untuk pneumonia this long? Kalau pneumonia this long kan, 2-3 weeks of pneumonia, what is the complication? What do you expect the complication is?
Abscess, lung abscess.
Okay, good, very good. Lung abscess. Okay. Pneumothorax tak?
Empyema.
Empyema thoracis kan, sama abscess, thoracis. Okay lagi? Itulah the main kan. The main is that, and usually patient will become very ill. Empyema thoracis will cause, and usually the symptom is persistent fever. It will not resolve because the infection is still there. So will continue. Okay, ARDS. Okay, ARDS, once you got sepsis, then you get ARDS lah. But you need to have sepsis and biasa very ill lah. You don't expect the child to still be alive after 3 weeks of pneumonia. Okay. Okay, lagi. Your differential, ada differential heart failure? What support heart failure?
Okay, could be reduced effort tolerance, lethargy, the patient has pallor, and then they cannot effort tolerance.
Okay.
There is family history of heart disease.
Okay, what against it?
What against it? There is rash.
Okay, rash.
Okay, sorry. And then infection and the history of fever.
Okay, so it's against heart failure. Okay, heart
tak
failure,
juga
is it a
lah.
diagnosis ke tak? Would heart failure a diagnosis or is it a complication?
It's a condition, right? Okay.
It's a condition kan? It's just a syndrome lah. Failure is actually a syndrome. Okay, syndrome of heart failure. Tapi is it, most of the time heart failure is a complication of disease kan? So in this case, what do you think causing heart failure? Actually, you are right lah. Okay, this is heart failure. So your differential will be rheumatic heart disease kan? Actually, rheumatic heart disease should be at the top of your list lah. Because this child got rheumatic heart disease. Okay, first, when you get cases like this, okay, you have to commit yourself lah. Okay, you kena ask about symptoms memang lethargic, shortness of breath on exertion. These are failure symptoms. Okay, then definitely now is you have to ascertain you have to confirm the failure symptoms. Kan, tanya dia, so nak failure symptoms senang je. Reduce effort tolerance lah, that is failure symptoms. Kan? Okay, and then now you want to ascertain what is the causes. Okay, so you dah tanya, I dah beritahu dah, ada fever 2 weeks, and then ada rashes. Then at the top of your list, definitely this is acquired heart failure kan, acquired heart disease. And dalam pediatric ada 2 je acquired heart disease, ada 3 lah. Ada, it's actually 3 lah, ada 3 acquired heart disease in pediatric. Adalah yang pelik-pelik tu, tapi the main is 3 je. Satu tu biasa kena ada underlying heart problem. So this child memang tak ada congenital heart disease. So you boleh rule out the other one. So ada 2 je. What are they? Ada 2 je acquired heart disease in pediatric yang common. Apa dia? And
Infective endocarditis.
IE, you need to have an underlying heart problem. You kan ada heart defect baru you dapat IE. Unless kalau dia IVDU lah. Kalau dia IVDU boleh dapat IE. Tapi we don't expect budak yang tak IVDU dapat IE. Unless kalau dia ada underlying congenital heart disease. Okay, in this case memang you boleh kata no underlying congenital heart disease kan. Then what is the other one? It's rheumatic heart disease dengan lagi satu is ada 2, apa dia? Kawasaki lah.
Kawasaki.
Oh, Kawasaki. Okay.
Ada 3 je congenital heart disease yang common in pediatric. Okay, IE, rheumatic heart disease dengan Kawasaki. Tapi Kawasaki, what is complication of Kawasaki? Do you expect Kawasaki come in failure?
Aneurysm, coronary.
Dia coronary aneurysm, dia mana ada failure symptoms. Kawasaki tak ada failure symptoms. And this age is very atypical untuk Kawasaki kan. Kawasaki is very young children. Biasa 1-2 years old, even less than that lah biasanya. You don't expect 10 years old untuk dapat Kawasaki. Okay. So you've got only one diagnosis, which is rheumatic heart disease. Okay, faham?
Faham tak, sir?
Okay. So you have to ask all the Jones criteria. So you kena tanya apa?
Oh, Jones. Okay. Dia sorry Doctor. Dia ada
arthritis kan?
Jadi polyarthritis.
So you kena tanya lah polyarthritis during the fever lah. Waktu fever tu you kena tanya. So waktu fever tu ada tak sakit-sakit sendi? I akan kata, oh memang dia sakit sendi doktor. Dia tak boleh jalan, dia tak boleh pergi sekolah. Waktu demam tu tak boleh pergi sekolah sebab sakit kaki. Dia mengadu sakit kaki lah, sakit tangan lah. Bengkak kaki, bengkak tangan lah. Lagi apa lagi? Polyarthritis lagi?
Involuntary movement.
Dia ada Sydenham-Korea kan. Sydenham-Korea usually late lah. Dia dah biasa dah subside fever atau towards the end of the fever baru dia akan ada Sydenham-Korea. And not all akan ada Sydenham-Korea lah. So until about 30% je akan ada Sydenham-Korea. Okay, lagi-lagi? So you akan tanya, ada clumsiness. Macam mana nak tanya Sydenham-Korea? Macam mana patient complain?
Jerky movement.
Sydenham-Korea biasa tak tangan jerking movement. Itu macam seizure pula. Biasa dia datang apa? Orang Korea datang dengan apa? How choretic child presented with usually?
Dia kata jalan pelik.
Dia akan datang dengan clumsiness. Okay. The description is clumsiness. I tak tahu clumsy bahasa Melayu apa. Saya tak pernah tanya dalam bahasa Melayu clumsy. Tapi bahasa Inggeris lah, I akan tanya clumsy, nampak macam pelik. Clumsy lah, clumsy. I tak tahu bahasa Melayu apa. Tapi they will come with clumsiness lah. Cakap asyik jatuh, jalan jatuh, tangan tak duduk diam. Macam tu. Pegang benda jatuh, tulis tak boleh. Tulis je conteng-conteng. So these are all clumsiness punya ni is very highly suggestive of Korea ataupun cerebellar punya lesion lah. Tapi usually it's Korea lah. Okay, lagi what else? So you ada arthritis,
erythema marginatum.
Erythema marginatum kan. So you kena, I dah cakap ada rashes. You kena ask to describe the rashes. Rashes tu macam mana? Is it gatal ke tak? Dia kecil-kecil halus-halus ke atau besar-besar bulat-bulat? And then dia kena tanya banyak kat mana, dia tanya kan badan kat kaki. Dia datang kejap ada kejap tak ada ke atau setiap masa ada. So this will describe, I mean patient usually can describe erythema marginatum very well because it's quite descriptive lah. Erythema marginatum is quite descriptive. Dia bukan macam rashes yang biasa ni. Okay, lagi-lagi?
Subcutaneous nodule.
Subcutaneous nodule. Macam you nak tanya subcutaneous nodule?
Ada bengkak tak dekat sendi-sendi?
Ada bengkak-bengkak tak kan? Dia not sendi lah. Biasa kat extensor surface kan. Tapi it can be anywhere. Dia boleh jadi kat spine pun. Dia boleh kat belakang kat mana. Tapi biasanya dekat dengan sendi lah. Kan? So ada tak bengkak-bengkak ketul-ketul kat bawah kulit dia? Encik perasan yang keras-keras ketul-ketul lah. Macam tu lah. Okay, lagi-lagi what else? Carditis kan?
Carditis, chest pain.
Ada tak chest pain? Failure is a carditis lah. First symptoms sudah carditis. Failure is carditis. Okay, kalau patient dah ada failure symptoms is plus carditis tu dah confirm lah, dah plus, dah positif, dah tick dah kat carditis. Okay, tapi usually you boleh tanya debar-debar ke, sakit dada, these are early symptoms of carditis. Okay? Okay, faham? Okay, any questions? So, how do you confirm diagnosis of rheumatoid heart disease?
To diagnose, based on the criteria, Jones criteria, 2 major or 1 major plus 2 minor.
1 major plus 2 minor ke? Ya ke 2 minor?
Kejap. 1 major.
Okay, this first episode you kena remember rheumatoid heart disease either first episode ataupun second episode, tapi this is no longer rheumatoid fever lah. Waktu kalau dia datang waktu rheumatoid fever, but now it's rheumatoid heart disease because patient dah ada heart failure. So dia kena ada fulfill 2 kan, 2 major ataupun 1 major, 3 minor, ataupun kalau recurrent then 4 minor is sufficient untuk you kata dia recurrent. Okay. So what else investigation wise? Apa yang you pernah tahu?
First to rule out pre-existing streptococcal infection, so do assault.
Okay, good, very good.
Okay, and then
apa lagi?
ECG, doktor.
Throat culture, good.
Sorry,
ECG.
throat culture. ECG.
Okay, throat culture lagi. ECG kan lagi? Lagi?
Full blood
chest X-ray kena buat, echo kena buat.
Oh.
Kan? Lagi?
Full blood count.
Okay, full blood count. ESR you kena buat. CRP, ESR kena buat untuk check for inflammatory markers. Okay, itu first simple je diagnosis je. You confirm the current strep infection, number one. And then second, fulfill the criteria, then you diagnose lah. And then you confirm by echo. Okay, so what caused heart failure in this? So what is the complete diagnosis?
The complete diagnosis is heart failure secondary to rheumatic heart disease.
Huh? Heart failure secondary to?
Rheumatic heart disease.
Okay, boleh lah. Boleh. Heart failure secondary to rheumatic heart disease. Okay, boleh lah. Okay, sometimes kita orang buat rheumatic heart disease with in failure ataupun rheumatic heart disease in failure lah biasanya, ataupun boleh lah heart failure secondary to rheumatic disease bersama je. Okay, so what cause heart failure ni last lah. Okay, what cause heart failure in rheumatic heart disease? So what cause heart failure in rheumatic heart disease?
Valve insufficiency.
Good. Okay, destruction of the valve lah kan, valve to destroy because of your punya immune system attacking the valve deflate. Okay, rheumatic heart disease is a pancarditis. The pancarditis dia affect all. So you can boleh dapat pericarditis, you boleh dapat endocarditis, but the causes of failure is usually because of you punya endocardial tissue lah. It's a endocarditis lah, the valve punya problem. Okay, so that's it. So which valve yang usually affected?
Which valve is mitral valve.
It's almost always left side valve, which is the mitral and also the atrial valve, aortic valve. Okay, ada soalan?
So patient ni kena bagi antibiotik betul? Prophylaxis.
Yes, definitely. You kena prevent. The antibiotic is actually to prevent recurrent infection. Because recurrent infection yang kills.
Patient ni dah ada rheumatic heart disease, dia dah ada failure symptom. So antibiotik tu kena setiap tahun lah.
Seumur hidup.
Setiap bulan. Seumur hidup?
Yes, seumur hidup.
Okay, doktor.
Patient with failure symptoms seumur hidup. So macam mana you manage?
Monitoring betul.
Monitoring apa?
Kalau patient sekarang for this presentation, if the patient present with fluid overload, so saya bagi to reduce the fluid overload by giving diuretic drug.
Before that, apa yang paling penting is you have to stop the inflammation. You have to remember lah, this is inflammatory condition. This is an autoimmune tau. Rheumatic heart disease is an autoimmune disease. So first kali ialah definitely you kena control symptoms lah, failure symptoms. Tapi you kena also prevent the inflammation from further destroying the valve. So you kena bagi apa? What is the treatment?
Aspirin.
Aspirin. Okay, aspirin kalau you tak ada severe carditis lah. Kalau once you ada heart failure, you tak boleh bagi aspirin. It won't enough. You can bagi steroid. So give high dose steroid. You start steroid to dampen the immune response. Okay. Kalau dia just carditis sikit kan, just carditis ke, just evidence of carditis, then you boleh bagi aspirin. Tapi kalau the severe carditis, you give both aspirin and also dia steroid lah. Okay, lepas apa lagi? Lepas tu you treat the failure symptoms using diuretics. Okay, kalau diuretics tak cukup, then you may need to add on spironolactone. Kalau tak cukup, then you bagi even digoxin. Can be 3 or 4 antifailure. Kalau usually this kind of case, chances are they will need at least 2 antifailure lah. Biasa Lasix dengan spironolactone. But most of the time, sometimes they need digoxin as well. Atau ACE inhibitor. Okay, good. Prednisolone ni. Okay, good. Okay. Any other questions?
Doktor, drug for cardiac protective nak kena bagi?
Apa dia? What is cardiac protective drug?
Selain ACI, yang kita boleh bagi cuma furosemide je untuk bukan specialized.
Okay lah, ACE inhibitor is the third, fourth line. Is the second and third line lah. We don't routinely give ACE inhibitor. Because usually furosemide is okay, is enough. Because in pediatric, it's not like in adult lah. Pediatric, the heart is good. Okay, the myocardium is good. Okay, because it's good, then usually by reducing the load, kan, the afterload is sufficient untuk relax the heart, untuk support the heart. Tapi kalau tak cukup, then you kena bagi ACE lah, ACE inhibitor ataupun beta blocker. Sama macam adult lah, tapi usually we don't need that. Usually by diuretics is sufficient untuk pediatric because the myocardium is good. Kalau adult punya heart failure, problem dia most heart failure in adult is caused by what?
Vascular problem.
Vascular, okay, lagi? So vascular is what? Is ischemic heart disease. Dia macam heart failure kan, you have to, kita classify heart failure by dia punya pathology tau, bukan by dia punya etiology. Okay, it's not correct to kata, oh, patient ni heart failure secondary to diabetes. That is wrong. Atau heart failure secondary to hypertension. That is partially right lah. Tapi actually the way you describe heart failure is, you can sebut ischemic cardiomyopathy. Heart failure secondary ischemic cardiomyopathy due to MI. Ataupun heart failure secondary to diabetic cardiomyopathy. Atau heart failure secondary to apa dia? Hypertensive cardiomyopathy due to uncontrolled BP, uncontrolled hypertension. Faham tak? Sama macam pediatric. In this case, this is a heart failure secondary to fluid overload ataupun secondary to valvular insufficiency. Due to biasanya dia prolapse lah, mitral prolapse atau atrial prolapse. Regurg lah, atrial regurg ataupun mitral regurg. Okay, faham? Ada soalan? Sama je macam heart failure secondary to high output cardiac failure due to hyperthyroidism. Itu pericarditis secondary to SLE. Macam tu lah. Okay. Atau dilated, kalau pediatric biasanya is dilated cardiomyopathy that cause heart failure. Because of viral lah. Biasa viral cardiomyopathy. Okay, ada soalan? Because you ada restrictive, you ada obstructive, you ada dilated cardiomyopathy. These are all cardiomyopathy that cause heart failure. Tapi has to be specified lah. Okay, ada soalan?
Doctor, for the diagnosis, cukup kriteria tu tambah dengan investigation yang evidence
confirm
of
straps.
Strap tu kan. So memang still positif lagi lah walaupun macam 2-3 minggu.
Okay, dia kan, you kena faham rheumatic disease ni kan, rheumatic fever ni is something dynamic tau. Maksud dia, usually kan, most people they don't get rheumatic heart disease from the first onset of rheumatic fever. Macam budak ni kan, dia memang ada 2 week history of rheumatic fever. But actually definitely previously mungkin dia dah ada. Dia dah ada strep infection. Multiple strep infection that cause, setiap kali strep infection tu dia destroy dia further. Sebab kalau contoh you ada rheumatic fever and then you check buat echo nampak ada trivial TR atau trivial AR. Then you tak start anti-failure. Your main treatment is actually antibiotic to prevent further infection, secondary infection, third atau second infection. Okay, tapi kalau usually this kind of case, dia dah banyak kali dah kena ni. So the main treatment is actually prevent further complication, further infection. Okay, and ASOT, biasanya kalau you buat ASOT dia akan positif lah because ASOT can last up to 2 months. Usually kalau datang dengan failure, maksud dia baru recently kena another attack. Okay, faham?
Thank you, Doctor.
Okay.
Doktor, sorry, boleh tak Doktor balik? Line saya tak clear sangat tadi.
Apa dia? Nak ulang apa dia? Apa dia?
Ya, assault tadi.
Okay, dia macam ni. Usually kan, patient akan datang dengan failure because after multiple attacks of rheumatic fever. Okay. Usually kan, what happen is, dia dah ada rheumatic fever and they've got some destruction of the leaflet lah. Tapi because the inflammatory reaction ni, dia wind down after a while, dia dampen after a while. Without doing nothing, dia akan slow, dia akan stop. And then second infection, dia akan trigger another inflammatory response, and this will attack the immune valve. So the valve will destroy further. And then third episode will destroy further. Fourth will destroy further. At the end, is sufficient, is the lesion that is big enough to produce symptoms. Faham tak? So usually, kalau patient tiba-tiba datang dengan failure, is usually because they got recent strep infection. And assault will be demonstrated lah. Increment in the assault, raised assault will be demonstrated. You faham tak? And assault ni, they last up to 2 months after infection. Usually, dia akan nampak, you akan nampak assault dia high. But be careful lah, assault again is not specific. It's specific tapi it's not sensitive. Means, kalau assault you negative, means you memang tak ada infection lah. Tapi kalau assault you positive, doesn't mean you ada infection sekarang ataupun recently. Could be like 2 months ago. Faham kan?
Doktor, kita biasa buat dua-dua ke, assault dengan throat culture for GABHS?
Sebut dulu. Throat more untuk acute.
Oh.
Okay, faham? Maksud dia sekarang. Kalau assault tu more to like chronic ataupun subacute infection. Okay.
Patient boleh datang juga doktor kan dengan masalah buah pinggang, kidney.
Boleh.
Kalau saya
Boleh, tapi macam ni. Tapi kan dia biasanya kan apa tu? Dia group B straps ni, dia ada 2 strain. Dia ada nephrogenic strain dengan lagi satu apa namanya? Cardiogenic strain. Okay, dia ada 2 subtype. Okay, usually the cardiogenic strain ni dia akan cause throat infection. While the nephrogenic strain ni dia akan cause skin infection. That's why biasanya and assault ni dia semua positif, dia semua sensitif untuk throat infection rasanya. Skin dia tak sensitif sangat. Okay, it can be negative in skin infection. Faham tak? So selalunya dos yang datang dengan throat infection, yang ni akan dapat rheumatic heart disease. Yang biasa assault dia memang positif. Tapi dos yang datang dengan apa tu, post-strep AGN kan, biasanya assault dia can be negative. Especially kalau dia datang dengan skin punya problem. Contoh dia ada impetigo, and then kita buat assault, could possibly be negative, and then dia akan datang dengan complication of post-strep AGN. Dia jarang lah, dia cause both. Jarang patient dapat both AGN and rheumatic fever. Saya jumpa dia seorang patient. Dia ada rheumatic heart disease, buat valvular replacement. And then lepas tu dia ada ESRF, CKD. Cuma CKD tak tahu sebab apa. Because post-strep AGN, they don't cause CKD lah usually. They cause AKI. Okay.
patient ni yang ada failure symptom, kita kena buat valve replacement doktor.
Kita budak-budak kita buat valve replacement. Later bila heart dia besar, you kena re-operate pula. Biasanya we treat medically lah. In pediatric we treat medically until dia dah teenagehood kan, dah 14, 15. Kalau still tak boleh control dengan medication, then kita akan buat valvular replacement lah. Because valvular replacement needs commitment. the mainstream of treatment is actually antibiotic lah. You prevent infection, further strep infection. It should be suffice. Usually kalau patient yang comply to you punya antibiotic, they usually have no problem. Those yang ada problem ni yang tak comply antibiotics. And then later on bila ada heart failure, kita bagi anti-failure, dia against lah. Kalau antibiotic pun tak comply, anti-failure pun tak comply kak. So dia akan ada problem. These are the people yang akan ada banyak problem. And we've got, and it kills tau. Contoh kalau you tak makan ubat, datang dengan severe heart failure, overload, and refractory, bagi lasik tak jalan, require dialysis. Usually these are the kind of people yang akan mati lah. Patient yang akan succumb. Okay, so
yang mortality tu masa umur dia
biasa teenage food lah yang problem. Waktu kecil senang je makan ubat. Bila dah remaja lah, ni yang dia susah sikit.
So they can die at early age lah.
Ya, boleh.
Okay. So nak take compliance tu yang susah lah kan. Okay.
Itu yang problem. Usually after age of 21 satu dia dah very low risk untuk dapat recurrent infection. So usually kalau macam patient ada mild carditis kan, kita bagi antibiotik sampai 21 years je. Tapi kalau dia ada severe valvular problem, then dia lifelong. And the best is actually antibiotic IM. Because satu jab can last about 3 weeks to 4 weeks. Problem buat makan ni itulah, you kena makan setiap hari, BD dosing, and it's pahit. So kalau jab you cocok, and then after 3 weeks you datang balik cocok.
Doktor, for the antimicrobial prophylaxis tadi, dia ikut kategori yang duration tu, yang kalau dia ada carditis and residual heart disease, dia sama ada bagi sampai umur 40 ataupun lifelong kan? Macam mana kita nak decide tu, lifelong ke sampai umur 40?
Oh, yang tu tak tahu pula. Yang tu adult yang decide. Suka tidur orang lah nak bagi sampai bila. Tapi I'm not sure lah.
Siapa yang decide?
I tak tahu sampai 40. Tu adult lah. Once dia dah adult, kita pass kat adult lah. Kita tak tweet dah.
International.
Yang tu biar pandai ada orang nak manage. But usually I tak pernah dengar pula 40 years tu. Ada 40 years
I found somewhere yang dia tulis duration after last attack tu 10 years or until 40 years of age. Tapi dalam kurungan dia tulis macam sometimes lifelong prophylaxis lah perlu.
So, biasanya our patient, pediatric patient, kita punya advice is you ni lifelong atau 21 years old. Because after, biasanya before dia goes to 21, dia dah pergi adult. So adult lah decide. Kalau adult kata nak continue sampai dia mati ke atau sampai 40 years old, tu up to adults lah. Because our evidence is until 21 years old. Betul lah. Because to transition to adult untuk rheumatic heart disease senang je. Because adult do manage rheumatic heart disease. So, tak sure. Tapi kalau pediatric, the things that our concern is, the things that our knowledge is only like 21-year-old ataupun forever. Okay. Simple je kan?
Okay, doktor.
Yang penting you have to think lah. You have to think. And you have to clarify everything. And then kalau you start, you just tanya Ais je. You just tanya Ais. Do you have any idea? Because parents, they read, you know. Parents read. Parents sometimes they read more than you. Sebab dia banyak masa kan. Dia satu je anak. Dia banyak kot patient nak fikir. Tapi anak dia yang sakit satu je. So dia banyak masa boleh baca. So they read sometimes more than you do. So ask them. Awak rasa kenapa anak awak sakit ni? Ataupun apa yang merisaukan cik sebenarnya? Okay, any other questions? Last? Before we end?
Tak ada, tak ada.
Okay, good. So the tanggungan tasbih kafarah.
Doktor, nak tanya
Apa
ni.
dia? Apa dia?
Yang doktor cakap tadi yang umur 21 kan? Yang prophylaxis tu untuk yang nocarditis kan?
Yang tu
Nocarditis,
kalau
no
dekat
evidence of
sekejap ya. No evidence of carditis sama 21, yes. Betul.
Sebab kalau yang 40 tu tak silap yang ada evidence of carditis dia kena lifelong ataupun 40 years.
Betul,
Up to
betul.
40 years.
Betul.
Okay, satu lagi soalan nak tanya. We know that rheumatic fever caused by the strep infection. So if we treat the earlier strep infection such as pharyngitis with antibiotic earlier, so is there any high chance still has chance to get the rheumatic fever?
Okay. There is chance to dapat lah. Tapi if you treat, then you reduce the chance lah. That's why if patient come with strep infection, throat infection, pharyngitis kan, you have to determine whether this is strep ataupun bukan. Because 90% of throat pharyngitis kan, more than 90% of pharyngitis is caused by viral. You don't need antibiotic. You boleh guna MAC score ke any scoring lah you boleh guna. Tapi most of the time is caused by viral. Tapi you cannot miss the about less than 10% yang caused by bacterial, because 90% of the bacterial is caused by straps, group B straps. And these are the group yang you kena treat. And the treatment is actually 14 days tau. Straps eradication is 14 days. Dia bukannya bagi 5 hari antibiotik dah stop atau 1 week. No, straps eradication is 14 days. They 10 to 14 days.
So if the patient compliance and the antibiotic treatment is complete, so still possible to get the rheumatic fever?
Still possible, tapi lah reduce lah.
Reduce,
and then
okay.
Secondly, you kena faham, kita tak tahu who will get the infection. And among those with infection, we don't know who will end up getting rheumatic fever. So the best thing is actually prevention. Okay, we know rheumatic fever, the main cause is actually congestion, over congestion, poor hygiene. These are the cause of infection. So that's why you tak ada lah. Those yang live dekat developed country kan, they never see rheumatic heart disease because they are advanced already. They have no problem with overcrowding. So bila tempat yang ada overcrowding ni ada strep infection, poor hygiene, sanitation, poor vaccination coverage, benda macam ni lah. So make sure you prevent this lah.
Okay. So Dr. rheumatic fever usually in peaks kan. So is it common in adult, macam dia umur 20 lebih ke still dapat rheumatic fever?
Boleh.
Primary punya. Okay.
Boleh. They can be at any age. Cuma usually after 21 years old, dia memang very rare lah after 21 years old. Tapi kalau macam contoh umur 14 tahun, 15 tahun, budak college, ramai je kena rheumatic fever budak college. Especially yang duduk satu rumah berpuluh orang kan. Sardin lah, contoh. I ada patient when I did my housemanship, waktu I buat cardio posting dekat UM tu, we've got one guy lah, tak kata boy. One guy 19-year-old budak college, datang dengan failure symptoms and it's rheumatic disease, very bad. Dan kita ada woman, perempuan, dia tak tahu pun yang dia actually rheumatic disease, dia tak pernah tahu pun. Because dia memang, the problem is kan, if you got rheumatic heart disease and then you've got some like mild carditis, you ada like mild TR atau mild AR, mild MR kan, and then you may not have failure symptoms, tapi contoh tiba-tiba you ada illness, you ada diarrhea, vomiting, ataupun you pergi panjat gunung ke, you pergi bersukan ke, atau in woman lah, biasanya you pregnant, so there's a high cardiac output kan, so this gives strain to your heart, so this is when your failure symptoms will erupt, will manifest. So a lot of women datang dapat macam heart failure symptoms in pregnancy, buat echo, ada MR, TR. MR, AR lah biasanya. So, and then check, walaupun memang ada contact disease.
Okay, doktor.
Okay. Okay lah, macam tu je kot. Okay, saya tanggung atas speaker Farah. Suratul As. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Thank you, doktor.
Thank you, doktor.
Okay, thank
Ya,
you.
doktor.
Thank you, doktor.
Terima kasih, doktor.
Okay, thank you.
Zen, keluar.